point of care. That's exactly what we're going to be doing today. And I'll be moving straight now to introducing our amazing speaker for today. Our speaker today is Dr. Brown Jacob. Dr. Brown received his doctoral pharmacy degree from Creighton University in 2010 and his Master of Science in Clinical Research from the University of Kansas in 2014. In 2011, he completed a PGy 1 pharmacy practice residency at Children's Mercy Hospital in Kansas City, Missouri, followed by a pediatrics clinical pharmacology. In 2014, Ram joined the University of Minnesota College of Pharmacy in the Department of Pharmacy Practice and Pharmaceutical Sciences, and is currently a tenure-track assistant professor. His area of research focus is within pharmacogenomics, pharmacokinetics, and pediatrics. Specifically, he studies the application of clinical pharmacogenomics in medication therapy management, mental health, and pediatric pharmacotherapy. Dr. Brown was the first author of the automoxetine clinical pharmacogenomics implementation consortium national guideline and is a co-author on the recently updated CPEC SSR SNRI guideline. So, ladies and gentlemen, it is with great honor and privilege that we have Dr. Brown join us today. I'd like to see the energy in the room as we make welcome our distinguished speaker for today. Thank you so much, Dr. Jacob Brown. The floor is yours now. Thank you.
Yeah, thanks, Destiny. Am I coming through okay?
Yeah, your camera is okay and your voice is loud and clear.
Okay, sounds great. Well, thanks for that kind introduction. Yeah, it looks like you guys have had a great 7 days now, I think, of PGx sessions. So hopefully this will be a nice sort of practical way to cap things off. I would I'm just looking to make this as practical of a session as possible for everyone. So feel free to interrupt me if anything is unclear. I'm going to try and jump between some slides that I've got prepared to talk about CPIC and PharmGKB and some other resources that the further you get into PGx, just the more you'll end up utilizing. And then I'm hoping to sort of pull up those websites and maybe just give a brief tutorial before we jump into some more clinical cases. And I've got those sort of divided up between fairly basic. It'll be a mix between published case reports that are in the literature, some basic case reports as well, and then a few more complicated ones towards the end. So feel free to interrupt me at any time if anything is unclear or I start talking about stuff that you're unfamiliar with. Again, I'm just trying to make this as practical as possible so that you guys can walk away from this session with a few different resources and a few different tools to approach utilizing pharmacogenomic results within clinical care. So like Destiny said, I am an assistant professor with the University of Minnesota College of Pharmacy. I have been up here for about 10 years now. So I did my PGy 1, which is a postgraduate year 1 residency here in the United States at Children's Mercy Hospital in pediatrics, and then stayed on and did a clinical pharmacology fellowship after that, which was much more research focused. As part of that experience, I was able to lead a project that looked at atomoxetine pharmacokinetics and then kids stratified by their CYP2D6 genotype. So giving everybody a comparable dose and then looking at what exposure differences kinetically look like. And then that kind of springboarded me into that CPIC guideline. So I think with that, I'll try to share my slides. Let's see here. This might take me 1 second. Destiny, I might have to email my slides to you because it's looking like my computer won't let me share. Is that okay?
Okay, sure. That's absolutely fine.
Okay. Sometimes they lock down our browsers a bit. So sorry for the delay on this one.
It's absolutely fine.
Might take a minute to come through, but I'll just start working through it.
All right, that's fine.
Okay. I just emailed you those slides, so hopefully you'll be able to get those in. Sorry, I didn't realize we're a Zoom university, and we don't use Google all that much, so I apologize for the delay on this one.
It's fine. Thank you.
All right, so I think while we wait, I'll just kind of start rolling on there. So yeah, this hopefully will be a hands-on practical session. I took some screenshots of things that I was hoping to pull up, but may need to just have you guys pull up yourselves. So our objectives for today is we're going to review. Destiny had mentioned that I am a member of CPIC. So CPIC is the Clinical Pharmacogenetics Implementation Consortium. And then we're also going to review PharmGKB, which is the Pharmacogenomics knowledge base. Those are two really important references. Again, if this is too basic, just let me know, and I can skip ahead. And then we'll look at some of the currently available guidelines, and then how those guidelines come together, what the evidence is for them, how authors end up sort of reviewing the evidence for that stuff, and then how medications are selected for guideline evaluation. We'll work through and look at what the guideline development process looks like. And then once we talk through that and some other resources, we'll start looking at some clinical cases to start reviewing. And those, again, are going to be a pretty wide variety. So some will be fairly straightforward, pretty basic, and then others will be a bit more on the complicated side. I also have a bit of a scratchy throat, so I apologize if I need to take a sip of water or coffee every now and then. Destiny, if those slides came through yet?
Yes, I'm trying to set it up now.
Okay.
You hear me? Yeah.
Yeah, if you're willing to project those, and then I can give you an idea of when to go to the next slide, that'd be great.
Okay. Can we see my screen?
Ah, yes, perfect. This is the beauty of modern technology. Yeah, if you're able to advance some of these. You know, Desi, can I try one other thing really quick?
Sorry?
Can I try one other thing really quick before we?
Yeah, sure.
I can't get it to work. I think this might have been a little easier than I was thinking.
I'm going to stop sharing now, so you try.
Okay. I think in order for this to work, I need to jump off and then jump right back on. I will be back on in like 2 minutes.
Fantastic. That's absolutely fine. Okay. Sorry about the inconveniences, guys. We'll get to it as soon as possible. Okay, great. I think you're muted. You're muted. Yeah, I think you're muted, Dr. Jacob.
Sorry about that. Yeah.
Okay, great.
Oh man, I thought this was gonna work, but maybe it won't. All right, sorry about that, Destiny. I think since it's recording, it's not gonna let me share my screen. So would you be able to pull those slides back up? Sorry, everyone.
Okay, no problems. Could it be? How did I? Okay, can we see my screen now?
Not yet. Oh, there we go. Okay, perfect. Could you go to the let's go to the second slide.
Okay. Okay.
All right, and then are you able to go into presenter mode?
I'm not sure that works. Oh no. Oh. Let me try to see how to figure this out, Dr. Jacob.
I think if you go to view and then you choose slideshow, it'll start projecting.
Sorry?
I think if you go to view up there, yep,
Okay.
and then select slideshow. Yep, there we go. Okay, perfect. All right. So Destiny, thanks for driving this. Could you go back a couple slides? All right, so sorry everyone. Again, feel free to interrupt me if you have any questions. I was hoping that it would be a little bit more interactive, but we'll just roll with this. Yeah, I'll try to keep an eye on the chat as well if anybody has questions in there. So our objectives, we're gonna, again, review the CPIC guidelines and then also look at PharmGKB. I've got slideshows in there. And so people feel free to pull those up as we kind of work through some of this stuff. It'll be, I think you'll get a little bit more out of it if you're kind of looking at it yourselves. We'll look at the currently available guidelines, what the evidence grading is, and then again, how CPIC selects medications for guidelines. And then also describe what that overall process looks like. And then after that, we'll apply guidelines to a few different clinical cases. So next slide, Destiny.
Okay.
All right, so the big thing, not the big thing, but one of the major debates that is ongoing about pharmacogenomic testing is when to test people and then what to do with the information. So a lot of times, especially when you're working with providers, they want to know, like, should this person get pharmacogenomic testing? It really depends, like if it's preemptive or if it's after the fact, if they've already started the medication. So there's a bit of a knowledge gap in there. Exactly who to test, depending on who you'll talk to and depending on sort of the disease state and what the drug gene pair is, you'll get kind of different information or different opinions on that. And so then the other thing is, what do you do when you have genetic information available? So CPIC definitely falls on the right side of this, these two circles. So they provide recommendations on sort of what to do with it. But there's a lot of debate, especially thinking about it from the economic or financial side of it. If health systems can afford this, if patients can afford it, really who gets the most benefit from it, and then when do you get that testing and what the recommendation would be. So a lot of times providers want more objective data to help with their decisions. Sometimes that's patient driven. So in this case, in the case of pharmacogenomics, obviously, doesn't get much more patient driven than that. And so CPIC decided to create these consensus evidence grades to help clinicians know what to do with the information once they have it. Next slide, Destiny. So PharmGKB and CPIC work fairly closely together. So again, PharmGKB stands for the Pharmacogenomics Knowledge Base, and then CPIC stands for the Clinical Pharmacogenetics Implementation Consortium. PharmGKB is housed out of Stanford University in the United States, and I've sort of heard them self-refer to themselves as like the Wikipedia of pharmacogenomics, and there is definitely a lot of information there. So if somebody asks me about a drug, if a drug gene pair or a specific medication, and whether or not that has any pharmacogenomic information available, PharmGKB is going to be the first place that I go. So if you pull that up, if you just Google PharmGKB, it'll be one of the first things that you'll see. So that I would just bookmark it if you haven't already. And so their primary aim is to collect, curate, and then disseminate that knowledge about the impact of human genetic variation on drug response. So the link is there. This information is all freely available, which is really convenient as well. Another nice thing is they have different pathways. I've got a few of those, I think, built throughout this presentation to be able to see. So they do a nice job of curating these pathways that then show sort of like what the metabolic profile of a medication is. And then a lot of times they'll include both in vivo and in vitro data. So they'll include things, include like a cytochrome P450 that's been shown in vitro to potentially contribute to a medication's metabolism, but then they'll put a little star typically if they're like one of those CYPs predominates over the others. And then CPIC was formed in late 2009. I think the first guideline that was published was kind of right after that and focused on TPMT or thiopurine methyltransferase, and then azathioprine and mercaptopurine. So that is, and again, that was a shared project between PharmGKB and then the PGRN, which I think some of you might be members of. And so really their primary aim is to address the major barrier of having a freely available, peer-reviewed, updatable, and then detailed gene drug clinical practice guideline. So next slide. So again, the purpose of CPIC is to provide recommendations for clinicians on what to do when that information is available. They do not get into the business of recommending who should have testing. They are generally operating under the assumption that eventually the technology will get to the point that we'll all have our own pharmacogenomic or sequenced results. And so their main focus is really on what do you do with that information when you have it. It looks like somebody has their hand raised. Do you want to, feel free to unmute yourself and ask questions. Maybe not. Okay, feel free to interrupt me if you do have a question. So yeah, CPIC, this is what the logo looks like. If you pull up their website, I've got a screenshot of it a little bit later. But they are designed to really help clinicians, and this is physicians, nurses, nurse practitioners, physician assistants, kind of thinking about this from a fairly US-centric point, but CPIC is very international and has members all over the world. And again, their main focus is, what do you do with that information when you have it? Not, yeah, this person's a really good candidate and you should order testing in them. So again, one of their other assumptions is that clinicians will be faced with having patients' genotypes available even if they didn't order the test. So we see this somewhat frequently in the US, and this will come up anywhere that people are regularly presenting with pharmacogenomic results or coming to the hospital or clinic with pharmacogenomic results. Where somebody may have ordered it to help guide like SSRI dosing or medication selection, and then that crosses over to cardiology or GI or whatever. Next slide. All right, so there are some key points about a CPIC guideline test, and if you can keep on advancing through here, I think there's some. Yep. So this is, again, based on the assumption that the test results are in hand and not to discuss the merits of doing the test. They're standardized formats, so I was going to pull up one of the guidelines and kind of show what this looks like. But if you pull up any of them, there will be sort of the table 1, and so that will give you some information based on the gene itself and what the common alleles are and what the common genotypes are. And then table 2 and on down will have actual dosing recommendations. And sometimes, so my training is primarily within pediatrics, although I've done research within the adult world as well. But some guidelines will even have separate dosing recommendations for children as compared to adults. So you may see a little bit of nuance within a different guideline. And it also just depends on how big the guideline is. So originally these guidelines were developed with like a single gene and a single drug. Now, especially like with that SSRI guideline, there's several medications involved, there's several genes involved. There's a systematic grading of evidence and recommendations, which we'll get into. They're peer-reviewed, so they all go through the Clinical Pharmacology and Therapeutics Journal and are reviewed that way. They're freely available, which is extremely convenient because you can find this information. They're updated regularly, kind of depending on the usage of the medication and what the priorities are. All the authors have a conflict of interest policy. They closely follow Institute of Medicine practices, and again, they're all published in Clinical Pharmacology and Therapeutics. Next slide. All right. Some of the formatting may be a little bit different. Somebody, I see a couple hands raised. People can feel free to ask questions if you want.
Okay.
Yeah.
Good afternoon, sir. Can you hear me? Hello, can you hear me?
Yep.
Good afternoon, sir. Okay. I think on the previous slide, before you turn over to this, you're talking about authorship and conflict of interest. I didn't quite get that. I don't know if you can portray on that, or if you can probably more emphasis on when you talk about the key points about CPIP guideline.
Yeah. So typically how this will work is CPIC will say, like, we want to make a guideline for, like sertraline and CYP2C19. And then the way authorship is selected is you then contact CPIC and say, I would like to be an author on this guideline. Here's the research that I've done in this area, or here's the, here's clinically how I practice within this area. I see this drug all the time. I use it all the time. I'm a great fit as an author. And so the conflict of interest is more like if you, have like, if you work for a pharmacogenomics commercial company, or like you have stock in a commercial company. And so you have some sort of conflict of interest that may preclude you from being included on that authorship because you have like some other financial interest that potentially could like sway your recommendation. Does that make sense?
Okay. Thank you.
Yeah. All right. Next slide. So yeah, at this point, this slide gets outdated quickly. So this is of August last year. So At that point, there were 28 guidelines, 17 updates covering 34 genes and over 160 drugs. You can see some of the genes and medications named there. CYP2D6 is one of the big ones. TPMT, I think, was one of the first ones. And some of these have been updated at this point as well. Next slide. This is CPIC by the numbers. There's over 750 members. It's really made up of a really eclectic group, I would say, of clinicians and scientists from across the world. I think in 2013 there were 89 members, and now it's over 7. It's probably over like 800 at this point. So there's quite a bit, quite a few guidelines encompassing quite a few genes as well as medications. There's representation in 49 countries. Again, that number is probably bigger now. Over 500 institutions. There's also an informatics group that works within CPIC that tries to provide recommendations for how to integrate this information into an electronic medical record. And there's observers at professional societies like the National Institute of Health in the United States and the Food and Drug Administration. Next slide. All right, and this is a very global international call. This slide is really appropriate. So this just shows where members are across the world. A lot of people are in the United States, Canada, but as you can see, there's quite a few people in Europe, Africa, Asia, all the way down to Australia and New Zealand as well. Next slide. All right, so this is kind of what the prioritization considerations for gene and drug pairs looks like. So this algorithm just kind of helps to kind of think through. So some of the main considerations when CPIC is considering creating a new guideline is how often is the medication utilized, so how often is it prescribed. Obviously, since this is a fairly international call, the medications that you are personally most interested in are going to differ a little bit between countries and practice settings. So generally start with what is that new gene drug. If the gene is already subject to a CPIC guideline, so things like CYP2D6 is on guidelines for like antidepressants, but it's also for atomoxetine, and codeine and several others. So if it's already subject to a CPIC guideline, sort of like that work has been established, that gets high priority. So then from there, there's an evaluation of alternatives and evidence. And then it gets the CPIC grade. So if it's A or B, it means there's a prescribing action recommended. It means there's enough evidence there based on available literature to make a recommendation. If it's C, there's no recommendation, alternatives are unclear, but people might test for it a lot. And then D, there's no action, there's really just not much evidence for it. So if the gene is not yet subject to a CPIC guideline, it gets prioritized a little bit differently. So they'll look at some of these other professional societies, like there's a Dutch group that also provides recommendations based on gene drug pairs. If it's nominated by a CPIC member or an outside entity like the FDA, depending on how the FDA or PharmGKB grades the annotation level, that can influence it, and then whether or not it's used in a professional society. And then ultimately, those also get a CPIC level. So next slide. This is the level of definitions for CPIC drugs and genes. So this just gives you a little bit of description on what the CPIC level of what they're calling the level of evidence. So this information you can also find on their website. So this is all taken directly from there. So they provide clinical context, level of evidence, and then the strength of the recommendation. So clinical context is things like for level A, the genetic information should be used to change prescribing of affected drug. This is the highest level, obviously. So in this case, it's like if you have that information, you should use it. You should be using it to guide either medication dosing or selection. Level of evidence. So what is that level of evidence for A? It's high or moderate in favor of changing prescribing. And then what's the strength of that recommendation? That includes at least one moderate or strong action recommended. So in this case, they're defining strong action as a change in prescribing is recommended. If there's information out there, but there's no real clear recommendation on what to do with it, it's going to drop a little bit lower. So next slide. And then there's evidence grades, and then there's guidelines. So evidence grading includes a preliminary assessment of that literature that supports the potential clinical utility of a drug-gene pair, and that link there will help describe what those are. And then a CPIC guideline is a little bit different. So there's sort of like the preliminary review that is a large literature review. It looks at basically everything that's available. And then a guideline is a more formal assessment of what the quality of the literature is. A lot of times as those guidelines are being developed, there will be several major finding statements, and then those will include sort of like a evidence grade. And so that can be something like it affects the pharmacokinetics of it, or like poor metabolizers are at a higher risk of adverse effects or something along those lines. Next slide. And then this is this evidence review. I apologize if this is a little convoluted, but it is kind of important background material. And so here the CPIC will assign levels of evidence linking the genotype to the phenotype. So if it's high, that means there's a high level of evidence. It comes from consistent results from well-designed, well-conducted studies. If it's moderate, it's a little bit in between, and if it's weak, it means it's the evidence is insufficient. So this could be insufficient for a number of reasons, including small numbers, small power, flaws in the overall design of the study, and then potentially gaps in evidence. Next slide. And then finally, we get to strength of recommendation. So this is what you're going to see within a CPIC guideline. So if you do pull up any of those PDF guidelines, you'll sort of see in like that table 2 where there is the dosing recommendations on the far right, they'll tell you what the strength of that recommendation is. And so this is based on weighing the evidence from a combination of preclinical, functional, and clinical data, as well as some existing disease-specific consensus guidelines. This can be based on human data, in vivo, PK, and also pharmacodynamic data as well. So you'll see all of these things within typically a CPIC guidelines. A lot of times the recommendation for like a normal metabolizer is going to be strong. Sometimes in those kind of far ends of activity, so people that are like ultra rapid metabolizers or poor metabolizers, typically is where there's just the least amount of evidence, because those people are relatively rare. And so it's hard to find large studies that looked at big groups of those. But if the strength of the recommendation is strong, it means the evidence is high quality and the desirable effects clearly outweigh the undesirable effects. If there's moderate recommendation, it means it's closer. It's uncertain as to whether the evidence is high quality, but there's clearly sort of like a direction that you would go. Optional recommendation, desirable effects are closely balanced with undesirable effects, or the evidence is weak, or based on extrapolation. So optional is typically like, we're pretty sure this is what would happen. We just don't have direct evidence or studies. Nobody has just formally looked at it and published on it at this point. And then no recommendation just means there's insufficient evidence, confidence, or agreement at this time. So rarely will a CPIC guideline get published that has like a straight no recommendation. Typically, when these things are starting to be developed, it's because there's some sort of actionable thing in there. I think the methadone is the only CPIC guideline that has a no recommendation, but there's also a guideline for it, so it's a little bit funny. Next slide. All right, I was going to pull this up and look at it, but you all are smart people and can do this yourselves. So this is just a screenshot of what the CPIC website looks like. And so at the top there, I would just say the far left, you've got guidelines. So that is going to link you to all those guidelines. They're freely available within those pages. Typically, the first link is going to be the PDF, and that's going to be the formal publication from Clinical Pharmacology and Therapeutics. That has a lot of background. They're well written. They're fairly short. You can get a lot of information out of them in a relatively short period of time. And then Genes and Drugs is going to look at all the medications with the level of evidence that they have. So some of these drugs will have guidelines, some of them will not. I'd really encourage you to just kind of explore this website a little bit. And then there's other information as well. So there are alleles. So kind of helping to describe like why they call a star 2 allele, whatever function that it has depending on the gene. There's good information there. All their publications are available. CPIC also hosts a meeting. Typically, they piggyback it onto another larger meeting like the PGRN or something like that. But they've been hosting annual meetings. And then they've also got informatics. They've got a members list, so you can see if anybody you know is on there. You can ask them kind of about their experience, and then if you want to contact. And then there's just some basic information in there as well. And if you explore this website a little bit, there's also a video somewhere on here that goes through sort of like how CPIC guidelines are developed and sort of what the thought process is going into them. So this is definitely one of them that this is a page that I'm frequently on, either looking up guidelines and what the recommendations are. I mean, a lot of my time is teaching pharmacy students at this point, so getting them comfortable with this website as well. So next slide. All right, I wanted to mention this group as well. So the Dutch Pharmacogenomics Working Group is a group out of the Netherlands, and so they write and update clinical PGx guidelines for Europe. They kind of work in parallel with CPIC, but they also do their own thing. So they have a consortium. They also translate this into several different languages, which is convenient. And these guidelines are endorsed by 6 European healthcare organizations. And sometimes CPIC will have a guideline for a medication or a drug gene pair, whereas the Dutch group will not, and vice versa. Sometimes the Dutch group will have a recommendation, whereas CPIC does not. Next slide. And then this is what the PharmGKB website looks like. I wanted to spend a few minutes pulling this up and just showing you some of the things on here, but I'll just try to talk through it. So this gets updated pretty regularly. One of the things that I would point out is that if you search within the bar, so if you go to something like codeine, and then you pull up codeine, it'll have several options on the left side there. And if there's a blue dot next to it, it means there's information there. And if there's not a blue dot, it means there is not information available. So if you look at something like codeine, and this is just something that I know is on there, you can go to clinical annotations, you can pull up the guideline, and then one of the really nice features is they'll have a drop-down bar. So if you know somebody's genotype, you know they're like *2, *3 for CYP2D6, you can punch in *2, *3, and then it will tell you what the interpreted phenotype is there, so like intermediate metabolizer or normal metabolizer, and then it will provide you what the recommendation is for codeine based on that genotype, if that makes sense. So the other thing that I was going to pull up that I think is a really useful tool is that genotype selection interface link. So underneath where it says, want personalized PGx recommendations, try the GSI tool. So that tool, again, is the genotype selection interface tool. I would highly encourage you to play around with that a little bit. And so what that allows you to do is enter genotypes or phenotypes, depending on the information that you have. And then it will automatically pull you to a screen that gives you all the medications that have CPIC, Dutch recommendations, or FDA recommendations based on the genotypes that you enter. So that is a really handy tool, especially if you have somebody's results, but you're kind of looking for how like PharmGKB or how CPIC interprets things. And then the other things that are pretty useful are those links down at the bottom. So clinical guideline annotations, that's going to link you to medications that have clinical guidelines. Drug label annotations, there are a lot of annotations out there. They're not all necessarily provide a recommendation on how to use them, FDA drug label annotations, and then curated pathways on the far right there. I have an example of what this looks like a little bit later, I think, for codeine. Hello, Zaya. But those, again, provide just like a nice, typically they'll have sometimes a pharmacokinetic, sometimes a pharmacodynamic pathway, sometimes both. And so they can be really useful for your own understanding, or if you're explaining this to a physician or another healthcare practitioner. Next slide.
Dr. Jacob, sorry, can you hear me?
Yep. Yeah.
Yeah, please, if you don't mind, I'd really like us to try again. I wasn't sure if you were co-hosts the other time you tried putting up your slides. I think you're now co-hosts. I don't know. Could we try to see if it works? Because I really think some of these things that you would have loved to show would really be impactful.
Yeah, I think unfortunately, Yeah, I think it's a security thing on my university laptop.
Okay.
The one thing I
Okay,
could do is I could try. You know what? Got a perfect laptop I can try this on. If you are willing to give me just 2 minutes, I can try that if that sounds good.
Yeah, absolutely. That would be fine. That would be fine.
Might be able to drive this both ways. Our university security has increased a little bit, I would say. And so if we're on Zoom, it'll work fine. But when it's like anything that's not Zoom, they don't enjoy that quite as much. All right, go ahead. I should be able to pull this up. Destiny, what's going on behind you there?
Yeah, I'm here. Can I should I put down my slide first so you try? Yeah, can you hear me? Should I pull down my slides so you try? Okay, sorry guys. I'm just thinking that having him present the slide from his end would really make more sense, because then he would be able to get to navigate through the websites, and you'd see that.
All right. Can you still hear me, Destiny?
Yeah, I can hear you. If it doesn't work, we could move on. It's absolutely fine. Fantastic. Yeah. You can see your screen now.
Okay. Sorry. Ooh, this is not what I was expecting. Okay, is this coming through okay, or is it not great?
Yeah, it's working great now.
It is. Okay, so do you just see the PharmGKB website?
Yes, you can see it.
Okay. Let me know if anything changes. So yeah, this is that genotype selection interface tool. What I was talking about here is if you come to this and you play around with this, if you throw in like CYP2D6 *4, like *5, something like that, and then you can include all the results that you want or as little results as you want, which is nice because you're not always going to have results for all of these. And then if you make the report, you'll see this is sort of what shows up. So it'll give you all the medications that are annotated for a CYP2D6 poor metabolizer. So you can see here that if you scroll down, it'll tell you what the CPIC recommendation is, what the Dutch recommendation is, if there are FDA or Food and Drug Administration label annotations, what those are, and then what the table of pharmacogenetic associations is there. The other thing that I wanted to point out is that if you search for something, so like I was talking about codeine before, these are what those blue dots that I was talking about are. If there's not a blue dot, it means the information is not there. And then if you go to prescribing info, and then you go to like annotation of CPIC guideline, then you can plug in what those results are, and then it'll automatically interpret it for you it'll tell you this is what you submitted as the genotype. This is the matched phenotype. So they're based on the two alleles that you put in. They're considered a poor metabolizer, and then for implications, greatly reduced morphine formation, leading to diminished analgesia. And then the recommendation is to avoid codeine use because of possibly diminished analgesia. And then the other nice thing is CPIC has made a short video sort of describing some of these different guidelines, and that you can watch those there. The other website that I wanted to just show you quick was the CPIC website. So again, this is what that main screen looks like. And then if you go to guidelines, you can see that if they'll have the guideline link, the medication, and then the gene. So if we go to like proton pump inhibitors and CYP2C19, the first link here will be the guideline, and then they'll have a bunch of these other tables that include some more kind of high level information, sort of like how they came to make those recommendations. So this will be like evidence linking CYP2C19 to the pantoprazole phenotype, and then yeah, other useful things here, potentially with like clinical decision support. Great. Destiny, can you potentially go back to sharing slides for me?
Okay.
I thought I could maybe do this on two different devices, but
is it visible now?
yeah, looks great. Yeah, and sorry, this is hoping to get to some of those cases as well, which we need to do. So again, this is what those clinical guideline annotations look like. It is really helpful to just play around on these websites and kind of see like what's there, what you can use it for. So next slide. And then a couple of these, I just wanted to show, if you've not seen sort of what a commercial pharmacogenetic report looks like. This is from a company called GeneSight. And so these are just screenshots taken from what their report looks like. This report is available on their website. So this is just sort of what their sample patient report looks like. And so on the right, you'll see they include some pharmacodynamic genes, but I just took a screenshot of what the pharmacokinetic genes look like. So they'll tell you the gene, what they call it. So sometimes they'll like extensive metabolizer, as you guys are probably aware, is sort of like antiquated, older language at this point. Typically you refer to those people as normal metabolizers, but they'll tell you kind of what their interpretation is. And then on the left, they'll kind of give you something of a interpretation based on sort of what they think. And so if it comes in that green column, the recommendation is to use it as directed. I just took a screenshot of antidepressants here. If it's red, it's a significant gene drug interaction, which doesn't necessarily mean that you can't use it. It just means you need to probably be aware that there's some recommendations there. And then moderate in the yellow is sort of in between. I saw there's a question in the chat that what is the difference between Pharm-GKB and CPIC? So CPIC is really focused on creating guidelines with recommendations on what to do with gene drug pair information when that information is available. Pharm-GKB is kind of more like a data warehouse for pharmacogenetic information. So I typically use Pharm-GKB as a reference when I'm looking up a medication and what genes potentially impact it. Whereas CPIC is more targeted, and so that is including like a guideline with a drug and a gene pair, if that makes sense. Destiny, next slide. And then this is another commercial pharmacogenomic company. Again, this report you can find on their website. This is OneOme. They use a little bit different of a interpretation, so they have kind of like a dashboard type thing, and then are giving you their interpretation of like a normal versus intermediate or poor metabolizer, and then they use kind of a similar interpretation where they either call it like a red major gene drug interaction, yellow is moderate, and then green is minimal. So these are available on their website. You can take a look at them. One thing I will say is that these commercial companies don't always interpret genotypes the same way. So there's a publication sometime in the last 10 years where somebody took the same DNA sample and they sent it to like 4 or 5 different companies, and then got like several different interpretations based on the different company. So just to make you aware, sometimes these things can be different. So CPIC at PharmGKB are nice because they consistently use an interpretation of what those genotypes are. So sometimes you can use these reports for results and then plug some of that information into like that genotype, that GSI tool on PharmGKB, and it'll give you like this PharmGKB CPIC interpretation of what those phenotypes are. I think somebody has their hand raised if you want to ask a question.
Okay, I have a question.
Yeah.
Sorry for interruption. This table, the gene and phenotype summary. I don't know. Can you like give a concise what do you call it now? Description of each and every of the table, like from the CYP1A to the CYP2B6, CYP2C9, CYP2C19, like that, and their interpretation with the phenotype summary and metabolic status. So we'll just get it in whole.
Yeah, so they're I think I get what you're at. So they're saying these are the genotype results, this is how we're interpreting it, and then they just like to give that visual of like, is it normal in the middle, or is it increased, or is it decreased? And then they give a short description of what that is. So a lot of times it'll be fairly consistent between like PharmGKB and these companies, but sometimes there can be differences. So like if you go like CYP2D6 down there, star one, so that's like wild type. So they're calling them normal metabolizer, and they're including that description in there. On the sort of the flip side of that, if somebody was a poor metabolizer, it would say something like severely reduced function, and then like reduced metabolism of the medication affected by this gene is predicted, or something like that. All right, next slide, Destiny.
Okay.
And then I wanted to just kind of show that there are some differences across PGx companies as it pertains to how in-depth their testing is. So these were just 3 different companies that I took a look at their reports, and then looked at how many different star alleles they tested for, and just looked at this between CYP2C19 and CYP2D6. So you can see pretty clearly that between these 3 different companies, like company C is most comprehensive. They are looking at the most, or they're reporting the most alleles, looking at the most variants, whereas something like company B has the least. There's a question in the chat: is it possible for these companies to follow a standard so the interpretations can be the same? That would be fantastic. But they kind of, at this point at least, are able to kind of like come up with their own interpretations. I think it's gotten better over time as things have gotten more standardized, and some of these companies have started to adopt sort of like PharmGKB and CPIC interpretations of what those genotypes are. And so I would say it's getting better, but just for your own knowledge, there may be some slight differences. All right, next slide. All right, so I wanted to just pose a few general questions before we jump into some clinical cases, and please feel free to, again, ask questions in the chat or unmute yourself. There's a few different things that I think are just kind of a helpful exercise to go through. So, and it depends a lot on the situation. So sometimes you'll have the situation that somebody has report already, or they've already had pharmacogenetic testing, they have their results, and they're asking you to interpret it and then maybe help explain previous medication trials, or help them to sort of select a medication or guideline. This can be preemptive or reactive. So Preemptive testing, obviously you're getting the test results prior to starting the medication. This is ideal. This is when you can really probably get the most out of that information, because you're sort of trying to avoid the adverse effect or the lack of response that you might see depending on what somebody's genotype is. The other question just to consider, is there a CPIC guideline? You don't necessarily need a CPIC guideline for every gene-drug pair to be able to interpret this or sort of make an informed decision. But if there is one, it's a pretty easy place to start and just get some background on it and see what the recommendation is. This could be CPIC, this could be the Dutch group. There's a couple other groups as well. Does it have a recommendation? So again, like generally, if there's a CPIC guideline, there's a recommendation. There is a rare exception, I think, where that might not be the case. The other thing I think that's important to think about is if just thinking in terms of like cost to the patient or healthcare system, thinking about if you got pharmacogenomic testing, is it going to change what you're going to do, or are you going to do the same thing either way? This might kind of lead you one way or the other if you're thinking, yes, this information is going to be really useful prior to starting, or no, I don't really have any alternatives, or like this patient is restricted based on insurance coverage or formulary inclusion. It could potentially just kind of sway you one way or the other. And then finally, especially if there is not a PGx guideline, is there primary literature available? So sometimes, especially, you'll get asked about drug gene pairs that may not have a formal CPIC recommendation or guideline, but you can still kind of do your own literature review and try to glean some information that way. Next slide. All right, so this first case is going to be, actually these first couple are going to be on codeine, and then I've got a sort of general case on tramadol here. So next slide. So the first two here are actually published case reports. So some of this information started coming out in like the early 2000s, or recognized that there were kids. So these first two cases are going to be relatively young kids after adenotonsillectomy, so their adenoids and tonsils taken out. And so in this first case, this is again a published case report. There was a 4-year-old undergoing adenotonsillectomy. They were discharged after an uneventful overnight stay on liquid codeine. So they were prescribed 8 milligrams a dose, up to 5 doses a day. So this was for their weight within the normal range of what the recommended dosing was. After discharge, they were described as sedate and lethargic, or the day after their discharge. And then, unfortunately, in this case, presented to the hospital after 4 codeine doses without vital signs. So on the postmortem, they did have a serum morphine concentration, which was elevated. And then they did CYP2D6 genotyping and identified this individual as a CYP2D6 ultra rapid metabolizer, which means they have a copy of one of their alleles, at least one. Depending on the assay, it's a little bit hard to tell how many copies they have. I think for most people it's like 1 copy, but there's been case reports of somebody with like up to 13 copies. That is probably exceedingly rare. But in this case, they were genotyped as a ultra rapid metabolizer, and unfortunately passed away. So next slide. And then this is a similar case. So at some point, these all started to get recognized a bit more, and somebody put together a case series on it, and there's now black box warning. But this was a 2-year-old boy that with sleep apnea that underwent also adenotonsillectomy. They were discharged on meperidine and then dimenhydrinate, and then instructed to take 10 to 12.5 milligrams of codeine with Tylenol every 4 to 6 hours as needed. So again, this was a dose well within what the recommended prescribed dosing is. And then for this patient, second evening after their surgery, they had fever and wheezing. And then the following morning, they unfortunately had no vital signs. So next slide. And so in this case, their postmortem, they had relatively low codeine serum concentrations, and then elevated morphine concentrations within their blood. And then this patient was also genotyped as an ultra-rapid metabolizer. So really what was going on here is codeine, which, as people are probably aware, is a prodrug, gets activated to morphine through CYP2D6. And so these kids were sort of just getting too much. So next slide. This is what the Pharm-GKB pathway looks like, which is what I was kind of referencing before. So these can be fairly complicated, but the nice thing is there's usually a write-up along with it at the bottom of the page that will kind of walk you through what's going on here. And then they'll put stars next to things that are active metabolites or the drug metabolizing enzymes that are most involved. So in the case of codeine, it requires bioactivation by CYP2D6 to morphine, obviously a active metabolite. So if you're an ultra-rapid metabolizer, you're going to have increased formation of morphine compared to if you're a poor metabolizer, which kind of puts you on the other end of the spectrum. Next slide. And then this is what the CPIC dosing recommendation looks like. So this is just sort of how I reformatted it. But if you go and look at it in the PDF, you'll see this is, I believe it's table 2. So on the far left, they'll tell you what the likely phenotype is. So anywhere between ultra rapid to poor. I don't know if people are familiar with CYP2D6 activity scores. CYP2D6 has a lot of different alleles, and so the activity score is just a way to sort of simplify that interpretation, and then they ultimately get categorized as like ultra rapid, normal, intermediate, or poor, and then it'll tell you what the genotype is, examples of that, and then implications for metabolism, and then what the recommendations are. So in this case, so if you're an ultra rapid metabolism or an ultra rapid metabolizer or a poor metabolizer, the recommendation is to avoid codeine. Because if you're on that ultra rapid end of the spectrum, you're going to overproduce morphine and be at risk of serious toxicity in the case of these kids. And if you're a poor metabolizer, you're not going to really get a whole lot of conversion from codeine to morphine. So you're going to have a lack of therapeutic effect there. Eamon, you had a question in the chat about CYP2D6 is less involved in the metabolism of drugs, so how we can consider it and associate it with drugs. I don't know. I'm not sure exactly what you're asking there. CYP2D6 is probably one of them that gets a lot of attention just because there's a lot of variety, a lot of genetic variation in it, especially depending on like where you're at and where you come from. And so different sort of like pockets of the world can have different percentages of like poor metabolizers or ultra rapid metabolizers. But it's one of them that gets a lot of attention because there's a lot of variability in it. And it is responsible for something like, at least in the United States, I want to say it's like 20% of the available medications. Next slide, Destiny. And this is what the Dutch pharmacogenetic working group recommends. So in ultra-rapid metabolizers, they recommend to avoid codeine and select an alternative that's not tramadol. Tramadol similarly gets bioactivated by CYP2D6, so the recommendation is to do something else. Next slide. And then I just wanted to touch on this a little bit. At this point, it was sort of recognized, at least for kids. So kids, just anatomically speaking, have fairly narrow airways. And so for kids that are undergoing adenotonsillectomy, they're having surgery in this area, it's already kind of small. Some of that inflammation that happens from the surgery in combination with potentially an overproduction of morphine from codeine is sort of what resulted in some of these unfortunate cases. So for the FDA, they added a black box warning to codeine's package inserts. So at this point, they restrict the use of codeine in cough medicines and tramadol in kids. And then they also recommend the use of it in breastfeeding women. So there's a case report out of Canada, I think, in the early 2000s where a woman was an ultra-rapid metabolizer, was taking her postpartum pain. Destiny, I think I'm getting a lot of noise from your microphone. All right. So,
yeah, sorry about that.
Yeah, no problem. So in breastfeeding women, morphine can be excreted in breast milk. So there was a case where an infant unfortunately passed away, and it was ultimately determined that it was from the mom converting codeine to morphine into breast milk, and then that breast milk makes its way to the infant. So the FDA now has that black box warning in there. Next slide. All right, and then a similar case, but in an adult. So this is a case where there was a 51-year-old Caucasian male referred to the pharmacogenomic clinic for chronic pain related to neuropathy and fibromyalgia. The chief complaint here was inadequate pain relief, and so this patient had a past medical history with neuropathy, fibromyalgia, as well as GERD, and then social history, had minimal alcohol and tobacco use, and no known drug allergies. So next slide. Their current medications were tramadol at 50 milligrams every 4 hours as needed for pain, duloxetine or Cymbalta, 60 milligrams once daily, and then omeprazole at 20 milligrams PO once daily. So their PGx results are included there. So I didn't include the depending on how we were doing on time, which I think we're a little bit short on. I was gonna make this a little interactive, but the one thing that I wanted to point out is that if you use that genotype selection interface tool on PharmGKB, you can plug these in. It'll tell you kind of what the interpretation is for phenotypes for those genotypes, and then you can get a recommendation from there. So we'll just kind of work through this. So CYP2D6 star 4, star 5 is a poor metabolizer, so those are both loss of functional alleles. For CYP2C19, star 17 is actually an increased functional allele. So if you have one of those, you're a rapid metabolizer. If you have two, you're an ultra rapid metabolizer. It really puts you on the increased activity end of the spectrum. And then for CYP2C9, star 1, star 1, that is considered normal. Next slide. So in this case, this patient would be considered a CYP2D6 poor metabolizer. This is a screenshot of what that tramadol CYP2D6 phenotype recommendation looks like. And then before, if you recall, when we were talking about sort of how they classify the level of evidence and classification, that classification and recommendation on the far right, in this case, is considered strong. So it means there's a high level of evidence, it's clear what the relationship is, and it's clear what the recommendations should be. In this case, somebody who's a CYP2D6 poor metabolizer, they are likely to have a lack of pain relief based on this. And so the recommendation is, if you're going to use an opioid, use something that is not tramadol and not codeine. I think somebody had their hand raised. If you want to, there was a question. Or maybe not. If you do have a question, feel free to throw in the chat or unmute yourself. All right, so next slide, Destiny. The other thing that I wanted to point out is that the University of Florida has actually done some additional research on the use of pharmacogenomics in pain. And so the x-axis is showing people's overall pain relief. So the farther down that bar is, the greater their pain relief. And then on the x-axis, you've got CYP2D6 intermediate and poor metabolizers on the left there, and then normal metabolizers on the right. And so you can see that when looking at normal metabolizers, there wasn't a whole lot of a difference between CYP2D6 guided and usual prescribing, probably because the recommendation there is going to be the same. But on the left-hand side, so people that had reduced CYP2D6 activity, if they used a CPIC or CYP2D6 guided approach, so using that pharmacogenetic information, those people had much greater pain relief in that IM-PM group as compared to usual prescribed. Next slide. And then the other thing that I wanted to point out is that this patient, so frequently, as you all are familiar with, people are on several different medications. Sometimes the same drug metabolizing enzyme can be included in there. Sometimes it might cross over for different drugs. But a lot of times when you're getting pharmacogenetic testing, you're not getting like 1 or 2 genes, you're getting like 12 to 20. So a lot of times there will be additional other medications that this may also apply for. So in this specific case, this person was a CYP2C19 star 17 metabolizer. That puts them in that ultra rapid phenotype. And so the recommendation there would be to increasing, basically double the starting daily dose. And the strength or classification of that recommendation in this case is actually optional. Next slide. All right, so I wanted to switch over and talk a little bit about just overall SSRI pharmacogenomics. And next slide. Antidepressants obviously are used quite a bit throughout the world. And so the SSRI-SNRI guideline was recently updated last year. So there are quite a few medications included on that, and then several different genes. Most of it is focused on CYP2D6 and CYP2C19. But in this specific case, this was a 26-year-old male of European descent diagnosed with major depressive disorder, and then lack of improvement on current therapy with a past medical history of major depressive disorder, social history, minimal alcohol use, no tobacco, no known drug allergies. So thinking about this relatively simple case, in this case, this person was on citalopram, 40 milligrams by mouth once daily. And then their PGx results were, again, CYP2C19 star 17. So again, that star 17 is an increased allele activity, and so this would be an ultra rapid metabolizer. Let's see, with the help of CPIC, we can find the genotype. Yeah, so CPIC will provide recommendations. Pharmacogenomics, I just really like those tools that are in there. So if you pull up like citalopram in Pharmacogenomics, and you go to those dosing recommendations, you can plug in like star 17, and it'll tell you what the recommendation is there. Next slide, Destiny. And then this is, again, a screenshot. So if you pull up the full SSRI-SNRI guideline, there are several different tables because there's just a lot of different medications. And then some of it's for CYP2D6, some of it's for CYP2C19. In the case of like sertraline, it takes into account both CYP2C19 and CYP2B6, B as in boy. But in this case, if this person was a CYP2C19 ultra-rapid metabolizer, not seeing the effect that you want, the recommendation here would be to consider a clinically appropriate alternative antidepressant, not utilized by CYP2. And if you want to continue using program to consider increasing the overall maintenance dose. So, for sometimes this information is most. A lot of feedback. I think from your end. But you have this information available sort of before somebody starts a medication. Again, it's really when it's, in this case, antidepressants obviously take a little bit of time before you start to really see an effect. But this also is a very common example where somebody starts an antidepressant, they try it for 4 weeks, they don't really see a whole lot of relief. Potentially their provider might get pharmacogenetic testing, and then sometimes that can explain essentially a non-response. So it's a little bit different when you're thinking about, do you have that information up front, or are you thinking about it sort of after somebody's already been on a medication? Next slide. I did want to include that there is a little bit of nuance in here. So with something like sertraline, if you're there's recommendations in there for only CYP2C19 and only CYP2B6. A lot of these medications are impacted by multiple genes. So I think just generally the direction that we're heading in the future is to take into account multiple genes and how they overall impact a medication and potentially a response or dose requirements. And so the one thing that I wanted to point out is, like, on the citalopram recommendation for an ultra-rapid metabolizer, it's to use a different non-CYP2C19 substrate as an antidepressant. But I will say, so sertraline, the recommendation for an ultra-rapid metabolizer is to use the standard starting dose. So there is a little bit of nuance in here with that. And then for sertraline, this is just me reformatting what the table looks like in the CPIC guideline. But they we'll provide recommendations if you have both CYP2B6 and CYP2C19 genotypes, so you can find it on one end, find it on the other end, and then sort of connect the two there. There's a question in the chat on the previous slide you were presenting. It's recommended based on phenotype. How can we detect it? How can we detect phenotype, I think is what you're asking. Yeah, so a lot of times either the report will provide an interpretation for you. Otherwise, if you, or the CPIC guideline can say, like, if somebody's star 17, this is their phenotype. Otherwise, like Pharmacogenomics has some really useful tools to be able to provide that interpretation. That's usually kind of where I start out. Somebody has their hand raised. If you guys had a question in there. All right, not hearing it. Destin, let's go to the next slide. And then one other SSRI case. So this was a 45-year-old male referred to their primary care physician for pharmacogenomic testing for depression and anxiety, which has been difficult to treat since it was diagnosed 10 years ago. They've tried several different SSRIs, including citalopram, sertraline, and fluvoxamine. This is a really common clinical presentation where somebody has tried several different SSRIs and just not been able to experience or find some relief. And then in this specific case, the patient has experienced excessive sweating since starting paroxetine. So next slide. For past medical history, they had depression, anxiety, as well as irritable bowel syndrome, social history about a beer a day, occasional marijuana use, and then current medications were paroxetine and bupropion at 300 milligrams daily. And then their PGx results were CYP2D6 star 1, star 2, and then 2C19 with star 1, star 17. So again, if you're able to, this is a really good opportunity just to pull up that Pharmacogenomics website, see what a star 1, star 2 is interpreted as. I just know off the top of my head, these are both normal alleles. So in this case, the person would be a normal metabolizer for CYP2D6, and then a rapid metabolizer for CYP2C19 as star 1, star 17. Next slide, Destiny. So the thing that I wanted to point out here is that this is a fairly common drug-gene interaction. So this is the Micromedics drug-drug interaction tool. And so bupropion is actually a strong inhibitor of paroxetine. So even though for their results, this patient is a normal metabolizer for CYP2D6, with the addition of that bupropion, for the duration that they're on it, you should consider them a CYP2D6 poor metabolizer. So this is a term called phenoconversion, which you may or may not have heard of, but if you see that in the literature, that's generally what this is applying to. Next slide. And then this is what the paroxetine pharmacogenomics pathway looks like. Paroxetine is actually also a inhibitor of CYP2D6, so that's why you see that red line go from paroxetine to CYP2D6. And then the main that main arrow, paroxetine to paroxetine catechol, shows that it's primarily through CYP2D6. So again, for the duration that they're on bupropion, even though from a genetic standpoint they look like a normal metabolizer, you should treat them as a poor metabolizer. There's a question in the chat: if a person is not responding at normal dose but respond at high dose, I would say if they respond at high dose, you could consider them a responder. For a lot of people, it's just that overall trying to find the right level of exposure within there. So if you have this information, you know their increased activity, you still want to try them on that medication anyways. You could be a little bit more aggressive either in like the starting dose or the titrating that dose up. And I think if ultimately you get that response, you'd consider them a responder. Next slide. So one other tool that I wanted to mention is that the University of Florida in the U.S. Created this phenoconversion CYP2D6 tool. And so if you Google this, it's pretty easy to find. But they have a nice sort of tool that walks you through. So you'll put in sort of somebody's CYP2D6 genotype. It'll tell you what the interpreted phenotype is there. And then they'll ask you, are they on any of these other medications? I think there's about 10 or so of them. One of them being bupropion. And so they're all either strong inhibitors or moderate inhibitors of CYP2D6. And then it will tell you like what the interpreted phenotype is for the duration that they're on it. Now, in this case, if this person discontinued bupropion, then eventually you'd consider them a normal metabolizer again. Next slide. So this is the dosing recommendation for paroxetine. So normal metabolizer, it's going to be initiate at that standard starting dose. Poor metabolizer would be consider a 50% reduction in the recommended starting dose, and then slower titration schedule. So it's a little bit tricky how all these things sort of line up. So if somebody starts on paroxetine, they're normal, you start them at the normal therapy, you add on bupropion, now all of a sudden you're really inhibiting or increasing their overall exposure to paroxetine for the duration they're on bupropion. And then if you pull them off it, obviously it's going to be a little bit different. So you have to think about some of those other drug-gene interactions in the overall context. Next slide, Destiny. All right, we've got 8 minutes left, and there's a couple more cases after this, but I think what would make sense is to go through this one and then maybe open it up for any overall questions that people might have. So this I just wanted to talk about as a combination of using pharmacogenomics with therapeutic drug monitoring. This is something that I know therapeutic drug monitoring is pretty common in Europe. In the United States, it really depends on the medication and then where you're at. So some places are doing pretty regular therapeutic drug monitoring, other places pretty minimally. But next slide, Destiny. For this example, so this is a case that we published in the Pharmacogenomics journal in 2017. So this was a 29-year-old Caucasian male. They had obsessive compulsive disorder and then recurrent depression with psychotic features. Their chief complaints included trouble concentrating, intrusive thoughts, excessive sleeping, tired throughout the day. So this patient was started on clomipramine, which is a tricyclic antidepressant that is broken down by both CYP2C19 and CYP2D6. So there is a CPIC guideline for this. This is one of the rare examples where there's recommendations based on both those genes, and you can kind of use them together. So they were referred to the CMM is comprehensive medication management in the United States. So similar to medication therapy management, but a bit more comprehensive. So they were referred to that CMM pharmacist who is also faculty with the University of Minnesota due to poor treatment response. So next slide, Destiny. So this patient was actually started on a relatively normal dose of clomipramine and then wasn't really seeing the effect that they want, or they were experiencing these other adverse effects that sort of muddied the overall clinical picture. And so they were started on a normal dose, and they were just gradually over the course of about 12 months, I think, increased to pretty close to the max dose. So in this case, we sometimes will kind of collaborate on these cases and talk through them and think about what kind of testing could be useful and what might help explain some of this. And so in this case, we did both therapeutic drug monitoring and pharmacogenomic testing. Tricyclic antidepressants have a fairly well-defined reference range, and testing for that, I think, is somewhat available. So on the right here, you can see what the clomipramine pathway looks like. It includes both CYP2C19 as well as CYP2D6. And when this therapeutic drug monitoring came back, the clomipramine level was well above that reference range. So their level was, or their concentration was 572 nanograms per mil. So well above that upper end of that reference range. And then desmethylclomipramine, the metabolite, was also more than double the higher end of that reference range. So looking at those two together was very elevated. And then correspondingly, their CYP2C19 genotype came back as an intermediate metabolizer, so reduced activity, and then their CYP2D6 genotype also came back as an intermediate. So not only were they sort of slow on one part, but also the other part. Sometimes if you have reduced activity on one, the other can kind of pick it up. But in this case, this person was an intermediate metabolizer for both of these genes, And so the recommendation was either to just try to go back to a pretty low dose based on what they were at, but based on their experience, this patient didn't really want to continue on clomipramine, which is pretty reasonable. So this is a case where if that pharmacogenetic information had been available before the patient tried clomipramine, potentially they would have been a little bit more conservative, I would say, in that dose titration up. But I just really wanted to point out that this can, using therapeutic drug monitoring and pharmacogenomic testing together can be really powerful between the two. A lot of times you might get a little bit of pushback from providers who kind of think like they don't really need both of them. And if you get one, like why would you have another? But at least in this situation, they kind of nicely lined up and ended up being a nice case report. There's a couple people with their hands raised. I'm not sure if that was by accident or not. All right, Destiny, next slide. All right, so this patient case is pretty long. I know we only have like 3 minutes left, so maybe I'll just stop here, Destiny, and see if anybody has any questions on anything that we covered. Yeah, there's a great question in the chat that a lot of these guidelines focus on the pharmacokinetics of a drug, but asking about how do we change things based on the pharmacodynamics. That's a really great question. I mean, one of the reasons that a lot of the CPIC guidelines are focused on pharmacokinetics is it's objectively it's easier to say, like in a poor metabolizer, their half-life, you know, is 5 times longer, their exposure is 3 times greater. If we sort of adjust the dose downward, we can get a comparable exposure with people in that normal metabolizer category, and then ideally have clinical outcomes. The clinical outcome piece is really the kind of the part that you're getting at, and really the part that kind of waiting on more research. And as that comes out, CPIC, I'm sure will continue to update those guidelines and include those additional genes in there. But at the moment, that's where the focus is, because that's where the evidence is. So I think as the evidence for some of those other pharmacodynamic genes come into play, we'll start to see those included in there. And then we're kind of getting into more of like polygenic type stuff, where it's like, all right, here's your genotype for this pharmacodynamic gene, which can impact, you know, maybe receptor folding or the affinity of the drug for that receptor, and then looking at that in combination with pharmacokinetics. Hopefully that answers your question. Let's see, a PharmD student in India, exploring pathways to the United States, clinical pharmacy roles. Let's see. Clinical pharmacists in the U.S., yeah. My understanding is that, oh man, I am the wrong person to ask for this. I want to say that you have to do pharmacy school here in order to be eligible for licensure. I am not 100% on that, so do not take my word on that. But a lot of times I think when people come to the U.S., I want to say that they have to do pharmacy school again and then take licensing that way. Having said that, there are potentially other more like academic routes where like you earned your pharmacy degree elsewhere, potentially within certain university type settings. They may take you on as like a PhD student or like a master's degree student, and that can kind of help get your like foot in the door in some of those situations.
Okay, that's great. I think I see a hand. I see Faisal Adamu. Faisal, you can unmute and ask a question. I think we still have like a couple of minutes, like just 1 minute. That will be our last question.
Sorry, please, it's a mistake. Sorry.
Oh, okay. That's absolutely fine. That's absolutely fine. Okay, so we no longer have Moses. Are you asking a question or?
Like her own, I think when we assessed that, it was partial.
Okay.
It was partial
Okay.
obstruction.
So now they are treating.
Okay. So sorry about that. So thank you so much, Dr. Jacob, for the amazing presentation. It's really great to have listened to you, to have seen the slides, and to have learned a lot today. Thank you so much. We are deeply grateful, and for your generosity, for honoring our invitation. We say a very, very big thank you on behalf of the whole collaborating organizations and the participants. I say a very, very big thank you. Well, sorry, everyone, we'll not be able to take another questions now. It's already time to go. So I'm going to allow Dr. Jacob go now, and we just have some announcements to make before we wrap. Thank you so much, Dr. Jacob. It's really been amazing having to learn from you today.
Yeah, thanks. Thanks for the opportunity to present. I apologize for the tech difficulties. Thanks for driving the slides. And yeah, thanks everyone for having me.
It's absolutely fine. Thank you so much. Thank you so much. All right. Participants, thank you so much for being around, and we're really grateful that you're still around up to this moment. No, attendance form will not be shared today. The attendance has been taken automatically, so attendance was tracked. So if you've been on the